Good evening, everyone. My name is Michelle Galazewski. I'm a Partner Relations Director with Eversight, and on behalf of everyone at Eversight, I would like to thank you for joining tonight's program, Making DMEK Better, the Preloaded Modified Jones Tube. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, please feel free to type your question into the Q&A panel at the bottom of your screen throughout the duration of the presentation, and we will address all questions at the end of the webinar. At this time, I would like to introduce Diane Hollingsworth, Executive Vice President of External Relations at Eversight, to say a few words.
Thank you, Michelle. Good evening, everyone, and thanks for attending tonight's webinar. We're very excited about it. We started our webinar series back in March of last year in order to continue ongoing education since we didn't have the ability to do in person during the pandemic. The webinars have been very well received, so we're going to be continuing with them with at least 6 per year. So stay tuned for our upcoming sessions. If you have a topic that you'd really like to hear about, please let us know. We also have been holding virtual wet labs for learning new surgical techniques. So reach out as well if you're interested in a wet lab, especially after this DMEK session. I also want to take a minute to remind everyone that Eversight is one of the largest worldwide nonprofit eye banks, and our mission is to restore sight and prevent blindness through the healing power of donation, transplantation, and research. To us, it's not just providing tissue for transplant. However, that is a very important aspect of what we do, and we do it well with quality tissue and dependability across the world. But in addition, our research department also allows us to engage in clinical research for not only corneal disease, but also for other blinding eye conditions. Our innovations department provides updates in corneal transplant techniques and new services with our vision of helping to end blindness worldwide. And I'd be remiss if I did not mention the eye tissue donors and their donor families. We honor them as they are truly what allows us to facilitate the precious gift of sight. So I hope you find tonight's webinar informative, and I'll turn it back to Michelle to introduce you to our speaker for this evening, Dr. Evan Pike. Thank you.
Thank you, Diane. As Diane said, this evening's speaker is Dr. Evan Pike. Dr. Pike is a fellowship-trained physician specializing in refractive surgery, cataract surgery, corneal disease and treatment, and general ophthalmology. He completed his doctorate of medicine at the University of Nebraska Medical Center, followed by residency at the University of Virginia Department of Ophthalmology. Dr. Pike continued with subspecialty training in cornea and external disease at the Ohio State University Wexner Medical Center. He is a provider at the Illinois Eye Center and a clinical assistant professor at the University of Illinois College of Medicine in Peoria, Illinois. Dr. Pike has co-authored articles in various peer-reviewed journals, including the Journal of Cataract and Refractive Surgery, and has presented original research at multiple scientific meetings at the national level. He has participated in several medical mission trips supporting international health initiatives to Guatemala, Jamaica, and rural Costa Rica. Dr. Pike is a member of the American Society of Cataract and Refractive Surgery, the Cornea Society, and American Academy of Ophthalmology Fellow. Dr. Pike, you can begin your presentation.
All right, thanks for having me. I guess it's always good to see everybody. I think we're all pining now for the days that we actually get to attend meetings, listen to lectures, and hear us share all the information that we're continuing to learn regarding eyes, eye conditions, eye diseases, especially cornea and cornea transplantation. And of course, I thank Eversight for the ability for them to allow me to speak to you about this. It's something that I absolutely love doing. Plus, they provide absolutely spectacular quality tissue when I need it for patients that are in need. So we're basically going to be, I'm in Peoria, Illinois. If you don't know where that's at, it's right kind of in the middle of Illinois. We're a few hours south of Chicago, a few hours to the north of St. Louis. We're kind of here in the middle, but we do have a very large subspecialty practice, and we do see a lot of pathology. So we're, my partners and I who span the subspecialty area, we do take care of just about everybody in our community, and we feel like we're our own little academic center, so we can share ideas and bounce things around each other. Just to kind of disclose, I do not have any financial disclosures with anything related to this lecture. Now, I'm not going to do an extensive review of DMEK technique. I think that there's many opportunities to do that. Obviously, we know that it's been around since 2009 when Garrett Mellis first started to describe it. It kind of further modified, and the goal was always to make it a more of a no-touch technique, or let's try not to manipulate the tissue as much as possible. And this is endothelial keratoplasty is what I really fell in love with when I was a resident, and what I was passionate about in terms of providing subspecialty and fellowship training. So I really love doing and seeing how this has continued to evolve. It's continued to improve. And I think that the Jones tube that we now have preloaded and pre-stained is one of those. And we know that tissue preparation has kind of been some of the biggest evolutions in any one procedure, DSEK, DMEK. Initially, it was just surgeon prep in the OR, which was, of course, time consuming and tedious. Then the iBank was able to do portions of it when the surgeon would then do another portion of it intraoperatively. And now we really rely upon our iBanks and their highly trained staff to both prep and load it. So it's really just used almost immediately ready when we have it in surgery. So why is it important or great to consider the preloaded, pre-stained tissue? I think that anytime we can touch and manipulate the tissue less is wonderful. So there's less of this intraoperatively. And as you can see in the video, this is what it looks like when it comes, and we'll show some more comprehensive videos in a bit. This will increase our efficiency. It reduces steps in surgery. It probably shaved 5 to 10 minutes off my DMEK procedure, which was incredible, and that allows us to schedule more, have more efficient OR time. Most importantly, we want to think about, is our graft and is our tissue safe? Have we seen any differences with the way this is versus traditionally prepared tissue? And so far, there does not appear to be, when you compare it to pre-stained graft, non-pre-stained grafts, we're not seeing significant cell loss, nor are we seeing a huge change in the fading of the staining of the tissue from when we do it intraoperatively until we do it or get it pre-stained and preloaded. Now, this is a little bit of an info slide, mostly for your direction to go to Eversight.org, and they have a very detailed sort of cover sheet that says, okay, here's what the preloaded DMEK tissue is like. Here's the specifications you can get it, and ways to get a little bit more information if you want to start utilizing this. I had previously received my tissue from them anyway, and so this was just an easy transition to start getting this particular tissue. Now, there are different choices when you have the preloaded tissue. There's a modified Jones tube and the Dork tube. If you're more familiar and more comfortable with that specific glass tube, you can utilize that. It has the longer neck, allows for amazing chamber stability. It comes attached and ready to use on any syringe, just as the modified Jones tube does. The modified Jones tube does have a slightly different connection to the syringe, which has really made things very easy in surgery. So here's how it looks when it comes. Instead of that kind of disc that you usually got with the tissue in it, it comes in more of a vial, and it's got the Life4C transport media. There usually is, of course, your scleral rim portion. So for culturing purposes, you have that, but it basically is ready to go. It has a cap on the end. So this silicone cap on the end, and of course the DMEK Connect is that connection to the syringe that allows you to not have to use, I used to use the 14 gauge gastric, French tubing, and you had to, it was like a little Lego set that you put together prior to surgery to put all these pieces together. Well, now it just comes ready and at the ready to go to load onto that syringe for insertion of the tissue. This is my typical Mayo stand, and it's interesting how my partners and colleagues in other subspecialties seem to always have new toys and new things to deal with, and I feel like we've become more sophisticated and simple in terms of our surgical instrumentation and setup. So I do use the SF6, a 20% SF6. So I do prepare that prior to the actual start of the procedure. My Mayo stand is there with a pretty simple setup of instrumentation. And then of course I have another table, a back table that's ready with a Pyrex dish full of BSS, almost full. And then I've got an empty 5cc syringe plus 0.12 forceps. And I also have the BSS on an angled cannula to help kind of get rid of some of that transport media. So I always look at getting the preloaded tube out of the vial, kind of like the game operation. You try to stay sterile, of course, and you try to stay from touching the sides. So this is me in surgery. I've got my circulating nurse brings the tissue, opens it up. Of course, it has that little plastic seal that they'll need to remove. And so I've got my 0.12s, try to keep my hands as stable as possible, try not to touch the edge or the rim of that vial. And then you can kind of grasp the DMEK connect portion specifically, as you can see right there, pull it out, try not to touch the sides. Don't worry, there's no buzzer that goes off like the game if you touch it, but you just try to be as careful as possible. And then I put it directly into that Petri dish or that Pyrex dish that's full of BSS. So this is what we used to do. I included this slide to kind of give us an example, and it's actually interesting to watch because I think it again highlights some of those steps that just kind of may touch or manipulate the tissue a little bit more than maybe what we want to do. So this is what I used to do when the surgeon myself would stain and strip it, but the eye bank had already stamped and kind of prepped it. So here it is. This is a little high speed, but it's got the S stamp on it. We got our rim. So we're kind of getting all, there's a little fiber in there I had to take out, get the Vision or the Trypan Blue in there so you can stain the edge, and it's already been cut. So you can kind of see the edges highlighted. I'm doing very, very, gentle techniques and grabbing that graft already. Of course, it's always pre-stripped up to that, that stained triangle on the scleral rim. So careful, 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 fill it up. And then the movie magic will take you through the 2 minutes that I usually have it sitting in the stain, and then you put it in the Petri dish. So I've already touched it a bunch. And then you'll notice as I have the Jones tube already made, you'll see how I kind of struggle a little bit to get it in the Jones tube. It's like, okay, it's not quite scrolled up, so it's not going to go. So you kind of use your little jet forces of BSS to try to get it to scroll up, try to get it to come into the Jones tube. And you can see how much wrangling I need to do. But I eventually get it, and it works okay. But I think that anytime we can touch that tissue a little bit less, we're going to help preserve the health and viability of those endothelial cells. So here's a video of the preloaded and pre-stained. So it comes looking like this. There's your cap on your left, the DMEK connect that goes onto the syringe on your right. I fill that 5cc syringe up with the BSS to roughly 4, maybe a little less than 4 cc's of the BSS. So I'll kind of show that to you right now here on that. So almost 4, pretty close. We want that pretty full. Obviously, bubbles are always your enemy. So no bubble, no bubble, no bubble. That's the rule when DMEKs are around, is it's a bubble-free zone. Then I just make sure that I have a good grip on it and make sure the entire end is submerged in the BSS. And I do a little gentle irrigation of some of the transport media out of there. We want, obviously, not to get that in the eye the best we can. So I come from this end to kind of get out a little bit of that transport media so it's not in the whole reservoir. And once I feel like I've done a good enough job there, then we can make sure you submerge the end of your syringe so you don't get a bubble right there at the connection point. But it's going to take a couple twists, and it goes on very easily. And then you also want to be sometimes kind of careful with the cap here, because you might get a little bit of a negative suction on there. So it may want to pull out when you pull that. So just be careful. You can always pull up on your the syringe to make sure you have enough back force. But most of the time, if you have a good connection, you're going to have a pretty stable graft within that reservoir. And as you can see, the little jet forces I give to remove some more of that transport media out of there. Now you'll see right, whoop, a little bit comes out, but it's right there, so you can bring it right back in. And if that's the most I touched it, I think that's still less than what we would usually see with the non-preloaded, non-pre-stained graft. So once we have it there, obviously we'll be done with this step and we'll kind of move on to implantation into the patient. So then you kind of get to the whole fun of unfolding and positioning. I use two 30 gauge angled cannulas. They have filled with BSS, and we use the gentle tapping and sweeping maneuvers to position. Obviously, you can use your quick tapping and sweeping, your slow tapping and sweeping to help manipulate the tissue. You want a soft, shallow anterior chamber. And at the conclusion, I put in the bubble of 20% SF6 into AC, and I credit my time with Dr. Greiner over at the University of Iowa for teaching me this technique and really opening my eyes to how much better this procedure has been for patients. All right, now we get to watch full case, but it's kind of going to be in a little bit of a warp speed. So I do get my grafts at 7.5 millimeters in diameter. So I want to strip about an 8 millimeter diameter. So that's what that corneal marker is. I do mark it all the way around so I don't lose that orientation. And we'll kind of mark 4 separate spots for the incisions, the ports that you can put your cannulas in to help move and manipulate the tissue. And this is obviously a pseudophakic patient. One of the other little tricks that I learned from Dr. Greiner was when you put your IOL in for lens implantation at the time of your cataract surgery, do make sure that you place those haptics at about 180 to be right underneath your incision to allow a little bit of a strut, so to speak, to keep the IOL stable as you insert the tissue and as you work with a very soft and shallow chamber. I did make the incision kind of infratemporally just a little bigger because we'll do a PI through that area. I use a reverse Sinski here to score the decime and to strip the membrane. And you kind of follow your marks that you already made. And if you have a good strip, you usually can use that reverse Sinski without having to put in another instrument to just remove that whole decimes in one single piece, which is always nice. So now what we'll do, and I put in a cohesive viscoelastic, that way we know we're going to get all of it out when we use the irrigation aspiration handpiece. So we've got all of it coming out. We don't want anything to interfere with the interface of our graft and the host cornea. So, and then we'll inject a little trypan blue. We want to stain to make sure we know we've stripped everything. There aren't any tags, loose ends, or irregularities that would otherwise inhibit graft attachment. So you can kind of see a nice stained edge at the borders of where we made those marks for the 8 millimeters, a little Myocol to help constrict the pupil. And then we'll do the PI. I'll make sure that it's patent with a little, irrigation of BSS through it just to make sure. And I can notice, and there it is. Always got to make sure that's patent. So now it's usually when we've got our patient's eye ready for the graft. And so again, we're getting the attachment of the preloaded pre-stained Jones tube, carefully taking off that cap. Again, you'll see a little bit of irrigation of some of that transport media. We make our incision large enough so to make sure to get the entire end of the modified Jones tube into the eye, into the anterior chamber, making sure that I use my left hand here to release a little fluid from that larger incision, because if we have a pressurized eye and that graft in there, that incision will open right up and that graft will disappear. So make sure you always have a good soft chamber, and you can even use that 0.12s to make sure you hold that cornea down on the incision so we don't exit, but I suture it right away. So once you get the suture in place, make sure it's rotated and is secure, then we can start getting our graft unfolded. Always makes it seem so smooth when you do it a little faster. So as you can already see, you got kind of a little bit of a, a 60-40 fold there of the graft as it went in. And you can do your best to watch it in the Jones tube. And as it comes out, sometimes you really just don't have too much control as to how it comes out when it gets into the anterior chamber. But if you can see, you can already see the S, and I can tell it's upside down. So we've got a backwards S. We got to do some nice little jets, and you can already see fill in the anterior chamber, using those forces of BSS to kind of let the graft roll, and we got it into our correct position. We're already seeing it's fairly, it behaves fairly well to unfold. We have almost got it. Want to make sure it's nice and centered. And sometimes those little quick and slow ways you tap and sweep will help you open up areas and then move it. So once I feel I've got it well centered, and just a couple little taps there on that temporal edge, and then we see that we have an S. Then it's time for the SF6, 20% SF6. We'll inject that. Make sure that all the edges look clear and clean. And then we'll make sure our incisions are watertight. We don't have any leaks. I do use a collagen shield at the end of the case that's soaked in cyclogel, moxifloxacin, and also some steroids. So we've got kind of a full gestalt there of what the surgery goes like, of course, in warp speed. So ultimately, what we're wanting to do is make it easier. We want more people doing DMEK because it certainly has shown top-notch results. Recovery in terms of patients. I saw somebody today, a week out was 20/30. You do see just quicker recovery to better vision with DMEK, and not to say, and not here to throw any shade on DSEK. It's a wonderful procedure that's still in my toolbox, but this just really shows results that are hard to beat. But we want to make sure it's safe. There doesn't seem to be any significant cell loss when you compare this to non-pre-stained grafts. It does maintain good trypan blue staining, so you don't lose that, so you can still see the tissue in surgery. We definitely are reducing the number of times we're touching and manipulating the graft, which is good for endothelial cell health. And of course, anytime we can make surgery more efficient, your surgery center also really likes that, but it is important, less time in the operating room for patients. And again, I think that this will make DMEK readily more accessible to people who are somewhat interested. They're thinking about getting into this. I think this is going to make it more accessible. Now, no doubt there's a little bit of a learning curve with this, but as there is with everything, and unless you start doing this and learning from someone who's done this, this will make it that much more easy. And of course, there are choices with the Jones tube or the Dork tube. So I really appreciate time. I know life is a little different these days, but this is how we get to meet, and that's just okay. There will be a time where we'll get to see each other and collaborate and find out how everybody's doing at meetings someday soon, and that's my hope. So I appreciate your time and attention, and thanks to the Eversight to invite me to do this for you.
Thanks so much, Dr. Pike. We do have a question. As mentioned earlier, if you have a question, please feel free to enter it in the Q&A panel at the bottom of your screen. So question number 1 is, when would you choose to perform DSEK over DMEK?
I have reserved DSEK kind of for those slightly tougher eyes that have other conditions. Let's say they had glaucoma and they're more of a bullous keratopathy change. Maybe they're not somebody who has Fuchs dystrophy. You know, I've really kind of utilized now DMEK solely for the Fuchs dystrophy patients that don't tend to have other problems. And DSEK's got a huge use for me when my partner has a glaucoma patient who has endothelial cell failure and loss, or patient has had a few retinal procedures and tears in their endothelial cells are stressed. And I think that DSEK in its own way, and I've kind of switched down to even ultra thin DSEK for those, is still very easy for those patients. Or if you have somebody who you're concerned, like what if you don't have graft attachment? Maybe somebody is not as easy to get back to the operating room. It's very tough to refloat a DMEK graft. I've not attempted it, nor do I think I'm going to. And a DSEK can be more easily refloated if it had to be even in the office.
Great. Next question from Darren Sy. Is there a concern about sealing the Jones tube both ends with silicone might affect the cell viability due to poor circulation of nutrients?
Well, I think that the top is not, is definitely not capped. And really, it's not going to be in there for that long. Yes, there's a cap on the bottom. I don't believe that its exposure to the transport media is going to be any longer than what you normally would expect it to be. Now, if there's some leaching or something of the silicone, I'm not aware that there's been anything out there that says that we need to be concerned about that specifically for this particular device, but I'm sure if that's something that, that can be looked at, we'd like to see the results of that.
In the meantime, I would like to thank everyone again for joining us today. The webinar has been recorded and will be available on our website to view on demand. Once you've completed your polling question, you can leave the webinar. A special thank you to Dr. Pike for serving as today's speaker and for providing us with your invaluable expertise on this subject. Have a wonderful evening, everyone.
Thank you.
Thanks, Dr. Pike.
Anytime.